We've reached the final point, but this isn't just another item on a list. In fact, this is the most important concept in everything we've talked about so far. Because number one is not a single medication, it's a pattern. A pattern that is affecting millions of older adults right now, quietly, invisibly, and often completely unnoticed. Here's the reality. Most seniors are not taking just one medication. The average person over 65 is taking 4 or more prescription drugs every single day. Many are taking 6, 8, even 10 or more. And that doesn't include over-the-counter products or supplements. Now think about that for a moment. Different doctors, different prescriptions, different systems in the body being treated separately. But no one always stepping back to see the full picture. And this is where the real danger begins. Because when multiple medications with anticholinergic properties are taken together, they don't just add their effects. Research suggests they can multiply them. That means a mild effect from one drug, combined with another mild effect, and another, can suddenly become something far more serious. A 2022 analysis published in Age and Aging tracked over 28,000 older adults. The findings were alarming. Those with the highest anticholinergic burden, measured using the Anticholinergic Cognitive Burden Scale, had a 120% increased risk of developing dementia over a 10-year period. Double the risk. Not from a disease that appeared out of nowhere, but from a combination of medications most people were never warned about. Let's make this real. Imagine a 70-year-old woman. Let's call her Dorothy. She takes a sleep aid every night, something labeled PM. She uses medication for bladder control. She was recently prescribed something for nerve pain, and every morning she takes something for acid reflux. Individually, each of those medications might seem appropriate, each prescribed by a different provider, each solving a specific problem. But here's what's really happening. Several of those medications carry anticholinergic effects, and together, her total burden reaches a level associated with significant cognitive risk. But no one told her that. No one connected the dots. This is not a rare scenario. This is happening every day, to people just like Dorothy, just like Margaret, maybe even someone in your own family. The medical term for this is polypharmacy, and more specifically, anticholinergic polypharmacy. And it may be one of the most under-recognized drivers of dementia-like symptoms in older adults today. But here's the part you need to hear clearly. Cognitive decline caused by medications is often reversible. That's not wishful thinking. That's clinical reality. When the total medication burden is carefully reviewed and reduced under proper medical supervision, many patients begin to improve, memory starts to return, thinking becomes clearer, the fog begins to lift, because the brain is not passive, it is adaptive, it is resilient, and when you remove the obstacles, it can recover. So what can you do starting right now? First, write down everything you take, every prescription, every over-the-counter pill, every supplement, even the ones you think don't matter. Second, look up each one using the Anticholinergic Cognitive Burden Scale. It's publicly available and easy to find. Third, schedule a medication review with your primary care physician. Use those exact words. A medication review to assess your anticholinergic burden. Fourth, ask about deprescribing. This is a real and growing field in medicine. It means safely reducing or eliminating medications that are no longer necessary or that carry unacceptable risk. And fifth, if your concerns are dismissed, seek a second opinion. You are not being difficult. You are protecting your brain. You can also consult a geriatric pharmacist. Yes, that specialty exists, and they are specifically trained to analyze complex medication regimens like this. Before we end, I want to hear from you. Which of these medications are you or someone you care about currently taking? Have you noticed symptoms like brain fog, memory lapses, confusion, and never thought they could be linked to a medication? Share your experience, because your story might help someone else connect the dots. If this brought you value, take a moment to like, share, and subscribe. Send this to someone who needs to see it, because the person who needs this information most probably isn't searching for it. Your awareness could change that. Stay informed, stay sharp, and take control of what goes into your body, because your brain depends on it. I need you to focus here, because what you're about to hear is not rare. It's happening every single day, quietly, behind closed doors in nursing homes, memory care units, and hospitals. And the unsettling truth is, most families never even realize it. Antipsychotic medications were originally developed for severe psychiatric conditions like schizophrenia or bipolar disorder with psychosis. These are powerful brain-altering drugs designed for very specific situations. But in real-world practice, especially among older adults, their use has expanded far beyond that. And this is where things take a troubling turn. Today, many elderly patients are being prescribed these medications not because they have psychosis, but because they are confused, restless, agitated, or simply difficult to manage. That's the reality. Not because it benefits them, but because it makes care easier in overstretched systems. That's not speculation. That's happening. The FDA issued a black box warning more than a decade ago, clearly stating that using antipsychotics in elderly patients with dementia-related behaviors increases the risk of death. But even with that warning in place, prescriptions continue. Now let's talk about what these drugs actually do inside the brain. Antipsychotics primarily work by suppressing dopamine. Dopamine is not just about mood. It's essential for motivation, movement, reward processing, and executive function. It's what helps your brain initiate actions, make decisions, and maintain mental sharpness. When dopamine is chronically suppressed, especially in an aging brain, the effects begin to stack up. Emotions flatten, thinking slows down, memory consolidation weakens, and over time, neurodegeneration can accelerate. A study published in 2022 in The Lancet Healthy Longevity followed more than 25,000 older adults. The findings were stark. Seniors who were given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within just 12 months. And here's the key point. Even those without a prior diagnosis of dementia were affected. Think about that. A medication intended to calm behavior may actually be accelerating the very cognitive deterioration families fear most. And yet, because the changes can appear gradual, subtle at first, they are often mistaken for normal aging or disease progression. The medication itself rarely gets questioned, but it should. If you have a loved one in a care facility, or if you yourself have been prescribed medications like quetiapine or risperidone without a clear diagnosis of psychosis, you need to ask direct, specific questions. Why was this prescribed? What exact symptom is it targeting? What is the plan to reduce or discontinue it? And most importantly, what non-pharmacological interventions have been attempted first? Because here's the truth. Behavioral symptoms in older adults often have underlying causes: pain, sleep disruption, environmental stress, unmet needs, that can be addressed without immediately turning to sedation. But addressing those causes takes time, attention, and resources. And sometimes, those are in short supply. You are not powerless in this situation. You have the right to understand what is being given, why it's being given, and what alternatives exist. This is not about rejecting medicine. It's about using it appropriately, responsibly, and with full awareness of the consequences. Because when it comes to the brain, convenience should never come at the cost of clarity. And if this is hitting close to home, if you recognize this situation in someone you care about, don't stay silent. Speak up, ask questions, advocate. Because sometimes, the difference between decline and dignity is simply whether someone took the time to ask why. Here's something most people don't realize. Not all medications in the same category behave the same way. And this next one proves that in a way that is both subtle and dangerous. Paroxetine, commonly known as Paxil, is classified as an SSRI, a selective serotonin reuptake inhibitor, the same family as medications like Prozac, Zoloft, and Lexapro. And when people hear SSRI, they usually relax a little. They think modern, they think safer, better tolerated, and in most cases, that assumption is true, but not here. Paroxetine is the exception, and what sets it apart is something that rarely gets explained clearly to patients. Unlike other SSRIs, paroxetine has significant anticholinergic activity. That one detail changes everything. Because now, instead of simply affecting serotonin, it also interferes with acetylcholine, the same critical neurotransmitter responsible for memory formation, attention, and cognitive clarity. The same system we've been talking about throughout this entire discussion. And when that system is disrupted, especially in a brain over 60, the consequences are not theoretical. They are measurable. A comprehensive review published in 2021 in Frontiers in Psychiatry found that elderly patients taking paroxetine showed clear declines in short-term memory and verbal recall within the first year of treatment, not over decades, within 1 year. And here's the critical contrast. These declines were not observed in patients taking other SSRIs at similar doses. Same category. Completely different cognitive impact. That's why the American Geriatric Society has placed paroxetine on the Beers criteria, a formal list of medications considered potentially inappropriate for older adults, specifically because of its cognitive side effects. But here's what makes this situation even more concerning. Paroxetine is still frequently prescribed to older adults for anxiety and depression. The very group that is most vulnerable to its side effects is often the one receiving it. And most of the time, they're never told. What starts as treatment for anxiety can slowly become confusion. What begins as support for mood can quietly erode memory. But because the changes are gradual, because they blend into what people assume is just aging, the connection is missed, again and again. But it doesn't have to be that way, because the solution, at least in concept, is straightforward. If you or someone you care about is taking paroxetine and is over 60, it's worth having a direct conversation with your physician. Ask whether switching to another SSRI like sertraline or escitalopram could provide the same antidepressant benefit, without the added anticholinergic burden. And in many cases, the answer is yes. Patients often transition successfully with a careful, supervised taper. No abrupt changes, no unnecessary risk, just a smarter alignment between treatment and long-term brain health. And that's the point here. This isn't about fear, it's about awareness. Because when you understand that not all medications within a class are equal, you gain something powerful. The ability to make more precise, more informed decisions about your health. And when it comes to protecting your mind, those small decisions add up. They matter more than most people realize.